Hello everyone, this is my final presentation for the pediatric rotation. My case study involves a urologic perspective. This child came into the office accompanied with her mother. Her chief complaint for the day was that she was having stress incontinence. She complained that the incontinence was worse when she was in her sport activities, such as volleyball and basketball, when she was jumping around. She reported that it has been lasting about 2 months. It had its sudden onset during one game. She didn't understand where it came from. She'd let her mom know, and since then she's been seeing that it's been happening quite frequently. She did deny any history of UTIs, any fevers, or hematuria. She reported that she had no problems with urinary incontinence in the past. She did report that she had daily bowel movements. She was unable to say if they were soft or hard, but when given a chart, which you'll see later in the presentation, they were more on the hard side. She has no allergies to any medications, and she reported that daily she takes a multivitamin. This 15-year-old female had her onset of menarche at age 11 without any complications. She denied any surgical history. Her family history included that her mother had a history of ovarian cysts, her father has hypertension, and her maternal grandmother had a history of ovarian cancer. This female does live at home with her mother and father. She's a freshman in high school. She plays volleyball and basketball, reports that she has many friends, and states that she's involved in a group at church. When obtaining her review of symptoms, she was positive for occasional abdominal pain. She also reported that she had urgency, frequency, and stress incontinence. Upon my physical assessment, there was nothing abnormal. General skin, hair, nails, ears, eyes, nose, throat, everything was as it should be. Her abdomen was soft, non-tender, non-distended. She had no pain on palpation. Upon her GI exam, everything was normal also. Her bladder was soft. Her external genitalia was normal. There was no irritation. And her Tanner stage was appropriate for age. With this child coming into the office, we did do a urinalysis, which showed to be negative. She was negative for leukocytes, nitrites, protein. Her urine pH was 6.0. There was no blood in her urine. Her specific gravity was in normal limits, and she was negative for ketones or glucose. We did obtain a pelvic ultrasound. It was completed after the child had given her urine sample, so we were checking for post-void residual. It was shown that she had a pretty significant amount of urine still left in her bladder. The PVR measured around 200 milliliters. Also, during the pelvic ultrasound, it was seen that there were large amounts of stool as we were ultrasounding the bladder area. All the stool was pressing on the bladder walls. So, upon listening to this child and her chief complaint, along with what we found in the diagnostics, it seems to be that she is having symptoms involving her urinary system. She is having dysfunctional voiding of her urine. She's having this urge incontinence, and we could see through the ultrasound that she was constipated. So when we talk about symptoms involving the urinary tract, this is a diagnosis that can arise from the urinary system of the child. This diagnosis is given to any child that has incontinence, infections, or any type of enuresis. The child with the complaint or the urologic condition then receives this diagnosis so that we can make a foundation for the chief complaint. She was also having dysfunctional voiding of urine. This is given to a child at any age who has difficulty voiding and symptoms that could possibly resemble a neurogenic bladder. This diagnosis is also given because this child continually contracts their urethral sphincter while voiding, causing them to not be able to empty, which we saw upon the pelvic ultrasound and her having 200 cc's left in her urine. The urge incontinence, this arises when the child needs to use the restroom right now. The urge incontinence is the child has a sudden urge that they have to use the restroom, and unfortunately, they sometimes have an involuntary loss of urine. This can be caused by something minor, or once we do some further testing, it could be caused by something serious such as diabetes. Finally, we're going to give her the diagnosis of constipation. This constipation for her was given because you could see large amounts of stool on this pelvic ultrasound. So what happens with the child who's constipated and is also complaining of this urge incontinence, what has happened is the retention of the stool has now led to this distension of the colon. The child then has decreased sensory threshold and doesn't think that she has to have bowel movements as normally as she would. So our plan for this child was to start a 2-hour voiding schedule. We would like her to use the restroom, urinate every 2 hours. We would like it to be the same time every day. We also like to initiate something called the double void. This can happen when she wakes up, while she's at lunch at school, and before she goes to bed. Double voiding is when the child uses the restroom, thinks they're done, and they stand up. Once they stand up, they do about 10 jumping jacks or wiggle around something and sit back down to try and use the restroom again. This will allow for full emptying of the bladder. Because of the constipation, we would like her to start 1 capful of Miralax daily. We also brought up the recommendation of performing a corn test to see the constipation and how constipated she exactly is. I'll talk about this more in the next slide. Also, it was recommended that she would perform a bowel clean out before she started the Miralax. So as you can see here, this is the Bristol stool chart. This chart we did give to the child in the office. When she was asked to describe her bowel movement, she was stating that the bowel movement was around type 1 or type 2. As a provider, future nurse practitioners, and from what I've learned in the office, we would like the types to be around 4 and 5. We would like them more soft to have the child have less constipation, therefore less pressure on the bladder, helping them to empty. So while talking to the patient and her mother, it was explained what we found upon the exam, in the urine, and on the ultrasound. We explained to her that her exam was perfectly normal from the outside. Her urine was clear. She had no urinary tract infection. But upon the ultrasound, we did find that she wasn't emptying her bladder and was also constipated, even though she reported that she had bowel movements daily. In this case, it was important to explain the voiding schedule and why it would be beneficial, that we basically need to retrain the bladder and tell the bladder we need to pee at these times every day. This will also help the emptying process. As I explained in the previous slide about double voiding, it was explained to the patient and her mother when to do it and why that would be beneficial. Also, we wanted her to do a bowel clean out prior to starting this Miralax. So because the child was constipated, the bowel clean out would help her kind of start all over. We would give a stool softener chew as well as 4 capfuls of Miralax in the morning. The child would drink this and chew the tablets, and by 6 p.m. at night, her bowel movement should be straight water. And that's what we had also told the family during the visit. Once the bowel movement has cleared and the child is starting from scratch, then they could start the capful of Miralax daily. Prior to starting the bowel clean out, it would be beneficial for the child and the parent to do a corn test, and this corn test is to see um, how constipated the child is. So we like to eat something that is able to be seen in the stool, such as corn or blueberries, and once the child eats the corn, it should take 24 hours to come out. So we tell the child, eat your corn, check your stool, see if it's in there. If it doesn't come out in 24 hours, then we do know that you are constipated. At this time, it was explained to the patient and her mother about the findings that we found during the visit. The plan was talked about and that it would be recommended to start as soon as possible. For this patient and her chief complaint, it would be considered that she would follow up in about 2 months to check the progress, and also that she could call the office with any questions or concerns if anything changed, or if she had questions about the corn test, bowel clean out, or anything about the plan that was talked about.